OsteoSignal Episode 8. This is OsteoSignal with Neil D. O'Neill, a podcast exploring how your body's natural design connects with osteopathic science, translating complex signals into practical insights so you can truly thrive.
Okay, we hear it all the time. Hormone replacement therapy for menopause, testosterone for men, weight loss, peptides for health. But what if the story we've been told is incomplete? On this episode of OsteoSignal, we'll dig beneath the surface. We'll contrast how HRT, hormone replacement therapy, is advised differently for women versus men, explore the emerging role of peptides such as sermorelin and GLP-1 and GLP-2 in the aging, metabolic, and regenerative equation, and ask the big question: how do these treatments align with restoring biomechanical, biochemical, and bioelectrical health? Expect deep dive, clinical nuance, and practical takeaways. So let's start off with this, just describing what the three signals of health are: the biomechanical, biochemical, and bioelectrical. These three parts of human function. Obviously, the biomechanical, everybody understands that parts work together, and that drives fluid. There's fluid drive. There's electrical drive, such as nerves, etc., and that drives your health and how you feel and how you're able to perform in life. And biochemical, I mean, obviously, we all understand that you have hormones. Those hormones are reactive to, like, for example, the seasons change and your hormone levels change, what time of the day it is that you like to get up, your dawn phenomena, et cetera, et cetera. So there's biochemical drive. If you eat things that are healthier for you or less healthy for you, that changes your biochemical milieu and causes you to feel differently. But then also bioelectrical. We want to talk about how bioelectrical, so when we really summate biomechanical and biochemical, that the mechanical action and the chemical action actually drive electrical flow that causes you health or ill health. And so it's an important part of understanding how humans function, to understand that there's these three components are all working together. They're all parts of each other, and they all drive each other.
Mm-hmm.
In the past, I think most everybody's been pretty aware of, there's biomechanical and even biochemical. Like, of course, yeah, we have chemicals going on. We take medications to change how we function. So we understand that there's signaling going on in our bloodstream all the time. But the bioelectrical may not be as obvious. That, for example, there is electrical flow in your arteries, that you have hemoglobin, which is iron, that then holds on to oxygen. And that iron is flowing through those tubes. Well, anywhere that iron flows like that, say in an iron foundry, there is an electrical discharge or an electrical field that causes electrons to flow. And in an iron foundry, they have to ground the tubes that the iron runs through. So it's very dangerous. Otherwise, people will get shocked to death quite easily. So it's like static electricity, but on a much larger scale. Okay, so it's very important to understand how those three work together. So the whole point of this podcast was to take those three signals of health, the biomechanical, biochemical, and bioelectrical, and then use that to view this latest Time magazine article on testosterone therapy for women. It just came out recently, and so it's been being talked about, and there are a lot of women, now it's being talked more and more about. There are women coming out saying, yes, I've started taking testosterone, and that they've had amazing results. Obviously, we hear the anecdotal evidence of the people who have had good results. We don't hear the anecdotal of the bad results, because people who have had their hair fall out or didn't feel any change or this, that, the other, don't continue to take it and then don't put anything on their social media account. So we don't get the negative anecdotal typically. You may here and there, but really the strongest one you always get. So you have to take that with a grain of salt of understanding people that have positive results are going to be the loudest and quickest and farthest reaching with their analysis. So we want to take that into account. However, there has been some real great things have come out of that, even though technically there's no physician in the country that would normally prescribe testosterone to you. Certainly some naturopaths or some people who are willing to go off label, or what we call black label use of a medication like that and prescribe that to a woman, have done so. That happens with every medication, so that's not something new, but it's not typically something that's done. And then in June 2002, there was an article on Time magazine that talked about how hormone replacement therapy, estrogen, progesterone, that when there was a research study done on women who were taking hormone replacement therapy in the 60s and 70s, the analysis was that 7 out of those 10,000 women developed uh, breast or uterine cancer. Okay. So then they redid the study in the 80s and 90s, and the research was kind of finalized and published in 2002. And Time magazine, of course, had a big expose on it, and that said, "Oh, in the difference between these two research projects, between the 60s, 70s research and the 70s and 80s, 90s research, instead of being 7 in 10,000 women who had contracted cancer, there had been a 50% increase, and 50% of that was 4. So now 11 in 10,000 women had contracted cancer. Now, because the Time magazine put out that it was a 50% increase in cancer, doctors freaked out, patients freaked out. Of course, it was a very newsworthy item and it was highly talked about. The problem
I
being that,
remember I was just getting started back then, and these women were
right,
talking about it in my practice, like, "Oh my gosh, I gotta get off my hormones." And you're like,
right,
"Well, hold on a sec. Hold
it was
on."
an emergency situation. Yeah.
Yeah. Oh, lots of distress. Yep.
The problem being that the physicians really and everyone else should have been going back to the research and saying, well, what are we talking about? Yeah, we're talking about going from 7 in 10,000, an inconsequential number, to 11 in 10,000, a nearly inconsequential number. I mean, obviously, for those 11 individuals, that's something. But in the context of public health and broad spread, like what should we do with this? The lens was not not appropriately tuned to be like, yeah, that's a speck, not a 50% increase of nothing is still nothing, and yet we had this profound change in how not only was it prescribed but how it was used, and so the benefits of hormone replacement therapy for women in a lot of ways were lost. However, for men, we see that men are, I mean, you can get a free sample of testosterone sent to your door by texting a number with, I need testosterone now, basically. And so men are doing testosterone left and right, going crazy. Now, men and women are not that different. If men are taking hormone replacement therapy, testosterone, then we would see a similar sort of problem. And we probably are. There are probably about 11 in 10,000 men getting prostate cancer because they're taking testosterone, an inconsequential number. So you haven't heard anything about it because nobody's worried about it. The men certainly aren't upset about that. So yeah, so in some ways we should go back and say, hey, look at hormone. And so right now, it's a big thing right now about peptides. And peptides are just the building blocks. They're amino acids. So they're small proteins, right? A peptide is a small protein. A large protein is like 1,300, peptides or 1,300 amino acids. So when we take a couple hundred amino acids, or even 400 or 500, then we call that a peptide. So it's important to understand the difference between, that a peptide is just a short chain of amino acids, right? Anywhere from 2 to 50 is the official word. So there you go. So peptides being neurotransmitters, basically, can have a profound effect. So we're talking about like I think it's BP 157. There's a couple different ones floating around right now. So in our introduction, we talked about sermorelin. So sermorelin is one such peptide that will induce your hypothalamus to produce human growth hormone, and we'll talk about that a little bit here. As to why you would want to do that. So this whole hormone replacement therapy, and now all of a sudden we have this whole thing where there are women taking testosterone saying, well, if it's okay for the men, then it's okay for us. And again, we would expect to see about 11 in 10,000 women have some form of reproductive cancer associated with that use, just like we did with the estrogen and progesterone use on the other one. So it's interesting that no one's bringing that 2002 study up. This latest study, this last year, just this year, it came up.
Yeah, February of this year.
Yeah, February
Yep.
of this year. There you go. So it's interesting how this information is all coming in. And of course, now we have GLP-1s. And I think everyone understands like Ozempic or Wegovy for weight loss, and understanding that peptide is part of the signaling pathway. It helps clear the signaling pathway between really the gut microbiome, the brain, the liver, and the pancreas. And so it helps that. Now, with that GLP-1, what we've seen is that everybody is on the GLP-1, and if they want to maintain whatever weight loss they've gained, you have to stay on that for the most part. I mean, people try to reestablish their better eating habits and their exercise program, and it is certainly a conduit to that. And some people are able to use that as a conduit to get them to that higher level of functioning, and then they don't backslide and they can go off the GLP-1. However, most people are seeing backsliding, that they gain weight back if they go off the GLP-1s, which is problematic. Now, so excitingly, there's actually a GLP-2, and a GLP-2, and I use the analogy, I've been telling patients about this. A GLP-2 is to actually heal the gut wall. The gut wall has been damaged by either the processing or the chemicals or the whatever, or just inflammation from a past infection, or or the immune system had overreacted to something, or had a high
Constant
reaction to
stress.
something, or stress has caused your gut to not function properly, and there's been damage to the gut wall.
Mhm.
Now, what my analogy is this, is that if you have a coral reef, it has all sorts of healthy things living in, crabs and shrimp and fish and eels, and then there are other animals that live off of those animals, and it creates an entire ecosystem. And the problem in the human gut, or all guts, but mainly the human gut that we're concerned with, is that if you have bleached that coral reef, a lot of those animals aren't there, and you don't have a healthy ecosystem. So even if you use a GLP-1 to restore the signaling is there, but you still have a bleached reef. So you need to bring the reef back. And so the GLP-2, ideally, that's what it's about, is healing that gut wall. Now, if you restore that coral reef, if you will, the gut microbiome now has an environment that it can live in. So what we may be seeing here, and I'm throwing this out here, understanding this, not just looking at the science, saying, hey, I want to kind of bring this to everyone's attention, that if we use a GLP-1, or we have patients who do, or a lot of people are going to come in contact with this, we should also be talking about the GLP-2 of bringing that coral reef back. You have to heal the gut wall to bring back the microbiome. And if you reestablish a proper communication between gut microbiome, what we call the brain-gut axis, and the pancreas and the liver and several other brain structures around the body, right? There are brain structures throughout the body that help regulate how we do visceral fat specifically. It would be one of them. If we can restore that, not only that signaling, but also make it healthy so that the gut biome is part of that and reintegrate the system, then we can have our patients go off of GLP-1, ideally, and that they've reestablished that gut wall and can maintain it themselves. So their coral reef will now be a healthy coral reef that maintains an ecosystem, as opposed to just a portion of an ecosystem, which is what the GLP-1s do. So we can really see the promise of a lot of these peptides, right? So of course, there's a reason we're very on about peptides. We've really begun to understand some of these, and we've looked at neurotransmitters in the past, like GABA or acetylcholine or what have you, and those are all very important. But we're also finding other peptides that are important, and we're bringing those to people, saying maybe we can help heal you and bring you back to health with this, which goes back to our biomechanical, biochemical, and bioelectrical. So some of these things are definitely needed, but then there's also the inflammation and the other things that we as manual therapists need to deal with. Part of that coral reef healing is that you have to get the system up and running, right? Part of the ecosystem, it has to drain out.
Sure.
So even if you put the right peptide there, that doesn't mean that the machine or the ecosystem takes off all on its own. There still has to be someone overseeing it and bringing it along. And that's using, for example, our Chapman's, our cranial technique, our Bennett's technique, which is organ-to-organ signaling. All the organ-to-organ signaling has to occur properly. The drainage of the organs has to occur properly. That's going to take manual therapists. However, these peptides are certainly a big part of that, helping restore what we've lost due to probably either viruses, bacteria, improper immune reaction, ultra processing, or diquat, paraquat, glyphosate that's in our food, that's in our air, that's in our water, that's destroying our guts. So
So would it be, I just wanted to chime in and just ask, so are you saying that manual therapy, it works in concert with, peptides or hormone replacement?
Exactly.
And do you think, what's your opinion about why people go on hormone replacement therapies in the first place? Is it just because they notice that their functioning is kind of dropping and they just need something kind of artificial to get them going again? Does that make sense?
Well, and maybe not going again. As we age, certainly our ability to produce hormones and to maintain health drops off. And part of that is the insults of, the universe exacts a cost upon us to live here, and in the form of viruses, bacteria, uh, contamination, even cosmic rays or X-rays or what have you. All those things break down our body, and our bodies are designed to break down at a certain rate. Unfortunately, sometimes some part of the body, or for example, the hormonal system, breaks down earlier, and a person wants to maintain health um, and vigor and youthful vitality, if you will. And of course, we say, well, what the difference may be. Your hormone levels have dropped, and if we bring those back up, you'll feel much more like you did when you were, 45 instead of how you do at 75. So that's why we
Before a
do
lot of
that.
that damage happened, right?
I'm sorry, say that again.
Sorry, before a lot of that damage happened to you.
Right,
That's what you're trying to
exactly.
get. Yeah.
Exactly. Back when you had your body was back when your body was vigorous enough to overcome, life's daily stresses and this, that, the other. So we're trying to bring back that adaptability and that youthful adaptability, if you will. So
Gotcha. So is using that coral reef analogy, and is like hormone replacement alone would be kind of just dumping a bunch of living organisms and saying like good luck
right,
on
exactly.
this
Like
dead reef, right? And then
right,
so manual therapy would be more like, you're creating an environment where those organisms could thrive.
exactly, exactly. Because someone still has to take the old chemicals out of the way, which is your lymphatic system. Somebody still has to restore biomechanical function, right? The shoulder has to work, the spine has to work, the pelvis has to work. Otherwise, every step you take, every breath you take doesn't pump fluids through your body, and chemicals build up, and the concentrations get out of whack, right? So much of life is about the correct concentrations of chemicals. And that's, if we keep them moving, movement is life, stillness is death. And so by constantly
Hmm.
mixing our internal chemical milieu, we're keeping healthy. And whenever that breaks down and stops working like that, when your knee stops working, your ankle stops working, or your back stops working, or your cranium is locked up, maybe that's a birth injury, maybe that's this, maybe that's that, then you have stagnation. Anywhere we have stagnation, we have advanced wear and tear, or what we call advanced aging.
I
Yeah, so
see.
you can't just
That's a
pour the
cool
chemicals in
analogy.
there. Yeah, okay,
Yeah,
perfect.
I love that.
Yeah,
That's great.
Yeah. And in adults, it would be advanced aging, right? In kids, because I treat a lot of kids too, they're not maturing properly. They're not
right,
developing the way they should.
right.
So, I
Their
mean, this can happen to
personality,
kids too. We're getting, our kids are eating, I mean, we just had Halloween, right?
right.
Kids just like overdosed on sugar, and now they're getting sick, and you're like, yeah, it's because that internal milieu is not turning over, and they're losing that adaptability. They're getting that damage now. And you're seeing it more as a developmental problem, whereas adults it's breakdown. And it's still breakdown, but it's more aging.
Exactly, exactly. So there's lack of reaching potential development, and then there's you've reached your development, and now you're slowly going down, aging, but if that process accelerates itself too quickly, especially in one area, then all of a sudden you lack bone density, or you lack the vigor to really go hiking or walking, which are the ways that we maintain health is by being active. So it's a big problem. So that's what the promise of peptides are, to help restore that possibility, right? But again, you also need that manual therapy to restore function, which is the mixing process. Like every step, every breath, every heartbeat, every production of cerebral spinal fluid, every one of those helps contribute to the health of the organism. Or you have an area that doesn't contribute and then lags behind and drags the rest of the system down.
Mhm. And that's what I'm seeing with my patients too that are taking like the Wegovy or the Ozempic and those kinds of things, right? They're looking better. They're
Right.
thinner, and they like how they look, but they're not necessarily healthier. And so we're having to use the manual therapy to get better blood flow to the gut, better blood flow to the brain, and all those different places. so that
Improve
it's
digestion.
not just looking better, but it's actually being better.
Right. You have to improve the digestion. They have to be able to take in those nutrients and calories. They have to be able to build lean muscle mass.
Right.
Right. It's much more complex than that. It's not that we're throwing the peptide at it and going, here, be magic. And it's like, it's not going to be magic. It's going to be scientific, and it's going to do what it can do. And you're certainly going to see a bump up, but they're going to be limited results, varied results, and sometimes lack of results. And then things like what's happening with this, the testosterone in women. One of the discussions of that was that many women are actually taking more testosterone than any woman produces in their lifetime ever. So it's not like they're taking a peptide to restore maybe the testosterone they had. They're taking levels that are on par with men and going, yeah, I feel great. I'm going to do this. Now, of course, there's going to be consequences to that. Some people are going to suffer them more. Some are going to be less. But what if we could get people to feel like they feel when they're taking really high levels of testosterone without them taking the high levels of testosterone, because the amount they take is more effective. And I think that maybe where the break point is like, let's take what is, within a normal range for you and make it more effective. Why would it not work at normally effective levels? So that's what I wanted to bring up and discuss and say, hey, look, so we need to look at this. And that and the GLP-2, that's kind of a new add-on as far as I'm concerned. That's kind of sneaking in there. People aren't talking about, you hear it, GLP-2 here and there, but you're not getting, like, what does that mean? So what a GLP-2 means is about healing of the gut. And then again, part of what we do as manual therapists is we also encourage the gut to signal properly, to get rid of excess inflammation, to move properly so that every step, every breath helps drain the gut as well and makes hormonal signaling, peptide signaling more effective. So that is really what I want to talk about, which is awesome. And that definitely, that is certainly part of the, an osteopathic minded or holistic framework, if you will, restore function and versus just simply replacing hormones. So you can replace the hormones. It may not have the effect that you want. And there's maybe bad side effects.
Awesome. Okay. So what would be the takeaway, do you think, for listeners?
So I think the
home?
takeaway,
we mentioned the combination of manual therapy and peptides or other hormone replacement.
Yeah, I think, we use the term osteopathic, and I think that, really encompasses like, what's a whole body approach to this? And it's not just going and taking testosterone. It's not just going and taking hormones. And as Autumn said, flooding the system with something and hoping that it has the right effect. It's about bringing that amount, that, those peptides into the organism, into the person, and having them maybe use those in a complex fashion, putting them together as a, you don't have an army where you're like, hey, let's just run out the archers and see how it goes. Then we'll run out the swordsmen and then we'll see how it goes. Or we'll run, hey, we'll just shoot missiles all day, whatever. You
want
you
to
don't
be
take one
smart in the
approach.
system.
You want to be smart in the system, and an integrated approach that covers all the bases, and then looks for where that organism, that person, is not functioning the highest, restoring function there to make these peptides more effective. Because ultimately, that's going to be what keeps the peptides from working. And understanding that if you take a GLP-1, you're probably going to need to take a GLP-2, but you're also going to need manual therapy to make sure that your gut functions. And I, for example, I had a patient come in and she's on a GLP-1, and this doctor has a whole program. And so she has a physical therapist working with her, and they were doing core strengthening, like, oh, you have to keep your lean muscle mass. Now they were doing core strengthening. I'm not sure what that has to do with lean muscle mass. As I think it was to prepare her for weightlifting. I think let's go with that. The thing is that, like, well, yes, that's great, but what about the GLP-2? What about balancing the sexual hormones, right? The testosterone, the progesterone, the estrogen. What about understanding these other aspects? Or for example, now let's jump into the sermorelin, because that jumps right into this. If you're a man and you're taking testosterone, it's going to shut off your native production of testosterone. And I've seen it. Researchers have kind of said that, on average, when the man stops taking testosterone, only about 20% of his native production comes back. So by taking testosterone, you actually turn off your own testosterone, which can be problematic, right? Because this testosterone is not your testosterone. Not all peptides are your peptides. There's huge genetic variance. So peptides these are the general peptides. It's not like a universal law that, was set down, this will be testosterone. It's like there are nuances to what testosterone is. There are little additives here and there that change how every organic compound functions. So, so a man and a woman, and by caveat here, will have much decreased native production. Sermorelin comes in and it doesn't create testosterone. It doesn't create progesterone or estrogen. What it does is it stimulates the hypothalamus to produce human growth hormone. Now, human growth hormone, otherwise known as androgen, will break down into constituents, whether that's estrogen, whether that's progesterone, whether that's testosterone. It will break down, and of course, these are chemical processes. So it'll be driven by local chemical processes. So if you have androgen come into an area, it turns into a sex hormone and says, here, let's make this work better. So actually, human growth hormone is a protein-based, it's a peptide hormone. And so human growth hormone will come in and have a very similar effect, in some ways broader based. Steroid hormones such as testosterone, they are lipid based, they're fat based. So they are slightly different. Basically, you take human growth hormone, you break it down, you add fat to it, you get testosterone. That's so that it can go into a cell through a cell membrane differently, right? A protein based is much harder for a cell to get inside. It has to actively take it in. Lipid based can actually come into the cell without assistance, but will also come in through assistance. And it has different attractants. Anyway, so the hormones act differently, but we want to know, like, okay, so should we give this person sermorelin to induce their hypothalamus to produce androgens, which has a general effect, instead of saying, oh, I want specifically testosterone or specifically estrogen. For example, I have patients who they can't take estrogen because they are too sensitive to the estrogen. So they'll be on progesterone only creams or pills. Whereas I have other women who the estrogen actually works far better for them. And then, of course, we see the latest write-up with this, that now you have women who are bringing in testosterone and they respond much better to the testosterone. So it shows you there's a big difference in all of those, but everybody responds to human growth hormone, right? So that gotcha. Restores vitality and function and helps the body rebuild. So again, going back to how do we integrate these? How do we bring those all on? Sermorelin is the one. And then, of course, that will not cause you to drop off your human growth hormone production. It simply provides the appropriate peptide for you to do that. So there would be the difference, right? If you give somebody testosterone, their native testosterone production will go down. We really care about that in men. Women, we don't care about it as much because that's not how testosterone is produced in women. So, again, how should we do this? Should we do testosterone for women, or should we suggest sermorelin or some similar peptide as yet to be, named? Certainly these things are coming out left and right. There's a lot of focus on it in research. So that's really the takeaway is like, what should you be doing? What should you be looking at? How do you bring this? How do you use this as an integrative system and not just using one? For example, should you be taking sermorelin and GLP-1? I think there needs to be a lot more thought, and that thought from doctors and from research is not going to happen unless we, the consumers, and we, the the users of healthcare, are demanding it. We have to demand. We want more clarity and better approach.
So sermorelin is a little bit more of a new concept for me. I have lots of people that are on GLP-1s, right?
Yeah.
GLP-2, I don't have as many people on anything like that, and it's not something I was. Until we were getting ready for this, I didn't know too much about it really. And I'm still learning. But that being said, usually when we introduce like a synthetic thing or we provide like an outside push for these hormones, we get some kind of a side effect. Is there some negative thing to be aware of if we use sermorelin or this testosterone in females? I mean, because then, we take it to extreme, then we've got the transgender things, right? So, we're getting at certain times and all that kind of thing. But for sermorelin or stimulating this growth hormone, is there anything that would be like we should maybe consider not doing that or anything like that?
Well, typically the research has shown that there are mild temporary side effects. Most common being reactions at the injection site, as with most things.
Sure.
severe disadvantages or long-term risks are very rare. But of course, you do want a physician overseeing this who would recognize that. As with anything, you can have
Yes.
injection site reactions, headaches, nausea, right? Nausea just means that the vagus nerve has decided it didn't like it. Dizziness or lightheadedness as hormones shift and swing. We can always get that. Flushing. Flushing very similar to taking niacin, right? If you take
Right.
niacin or B2, right, it'll cause facial flushing, face and neck. You could get fatigue and excessive sleepiness because it is swinging your hormones.
Okay.
Changes in your taste, temporary water retention, so bloating. And again, and then that goes back to the manual therapist of,
That's what we
you're
do.
going to see an effect, right? But did you
Yeah.
already have an area that held on to inflammation?
Right.
Or does your midgut already dysfunction? And then you take this peptide and you didn't get the positive result you expected because you have an area that is not functioning at its highest. And so now we challenged that area, and that area is not up to the challenge. And so you see a local, which there's the beauty of it. By using sermorelin, whatever side effects you do see tells your manual therapist, guess where you need to go look.
This is where you need work.
This is where you need to look.
Yep.
Work. Yes.
Yep.
Exactly. So, I mean, so that part is, okay. And there's all of these have side effects. Now, and I said, like maybe we should be giving people sermorelin in conjunction. Now, I'm not a doctor. I'm not playing a doctor here. What I'm doing is I'm asking questions, and I'm hoping these questions get back to physicians and get back to research docs who are going to go, oh, we need to tell people what we think they should do because, we're the experts on it. So, benefits of sermorelin include improved energy and sleep, increased lean body mass. What's one of the deficits of GLP-1s? Decreased lean body mass. However, sermorelin also reduces body fat, enhanced recovery and performance. People have also reported like better skin tone, better mood, increased libido, et cetera, et cetera. I mean, all those things that we thought maybe I should take testosterone for, or maybe I should take hormone replacement therapy of some sort for, or even maybe I need a GLP-1 so that I can get my life back. So we see a lot of these peptides being used, and I really want to encourage people to investigate those, ask questions, and really we need to get answers about how can we put these together and have a more effective treatment. And as manual therapists saying, yes, I have patients on these and I want to be able to go in and say, okay, tell me your reactions from this peptide so that I can pick out where I need to work through your body. How do we enhance the effect of the peptides? And people should
really
be demanding that
better
as well. Right, exactly.
It really, it makes them better, but traditional medicine better. It gets better research going, and it helps us as manual therapists go, I really need to know how the body works. I really need to know how these systems work together, or how the organs do communicate back and forth. So it pushes all to be better.
You should be taking this peptide. You should be taking that peptide. You should take this. You should take that. It's like, that's great that your cousin's wife's son's brother's dog took the, it's like that's great. But what should you do? And what's the information for you specifically? What are your breakdowns? And then also, even though you take this medication, you're like, yeah, it's not helping like I was hoping that it would. Whoa, hold on. Come and see one of us and let us follow you through that process and say, where is the disconnect? Where's the disconnect in the biomechanical, right? You can't build lean muscle mass if you have a bad shoulder, or if you don't have proper blood flow, or you don't have proper venous drainage, because something will get too swollen and it'll be too sore and you'll stop working out. So none of these things are going to work in a vacuum. You have to put them all together, and we have to be complex about our approach to this. Humans are complex. Our approaches to treating them have to be complex.
Yeah, I just wanted to just chime in and say, anyone listening, don't think that you have to run out to a doctor and say, please tell me what hormones I need to be taking right now, right?
No, totally.
It may not be the case for you. So any. So don't think that we're advocating. We're not advocating for that. Just understand that if your doctor recommends it and you choose to follow it, manual therapy can help you get the most out of it.
Exactly. That you should have a manual therapist as part of your healthcare team, helping you get the most out of it and restoring most of that function. And then the benefits of all of that will be far greater.
Right. Well, that's exciting. I hadn't
it's just interesting.
ventured up into that. Yeah, it's going to help me do a better job for sure to,
Right.
clue into that stuff better and then be like, okay, maybe, as we're going through the healing process and as they progress to using like Ozempic or whatever they're using, right? Okay, this is what's happening here. Maybe check with your doctor about this. Ask him about the GLP-2s or ask him about sermorelin or, different things and see what he says, see what they say. She says,
And you may not have a physician that's aware of that, and maybe you need to go and find other sources.
Exactly.
The thing is there are, as Brent was pointing out, it's like, I'm not suggesting people do this, but I am completely aware that a lot of my patients you're hearing this on the radio, you're seeing it in, it comes up on your, news feed constantly. You're being, everybody's trying to sell their product. And so understanding like what's good for you, what's bad for you. And that's really what I want to speak to about, hey, first off, when you're looking at this stuff, take it with a grain of salt, first off. Do speak to a healthcare provider who can guide you through that with your specific problems, but also understand that not every health provider knows everything about every one of these. And so researching yourself, and now that's the other kind of guiding principle here with this podcast for this cast, is that we want people to kind of be aware there is sermorelin, there is GLP-2s. What do they do? What's, how might you think about that? And if you don't get an answer, because you do have a lot of people out there that they are a one-trick pony, like, I do GLP-1, let's go. And that's all they do, but they never progress to GLP-2. They don't say, let's do sermorelin with this to make it more effective because you haven't lost the weight or you haven't made the gains. Why not? And what other things can we do? Maybe you should be seeing your manual therapist to make it work better. I mean, I have patients who come in all the time and they're overly nauseous with their medication. They're like, unfortunately, I think I need to stop my medication because I'm overly nauseous when I take it. And I ask them, well, where did you take it? And they say, well, in my upper abdomen. I said, well, if you take it in your lower left quadrant of your abdomen, it's going to have less of an effect on your vagus nerve because your vagus nerve doesn't innervate down there, right? Your vagus nerve innervates along the diaphragm and the lower right quadrant, but not the lower left quadrant. So you'll reduce your nauseousness and yet still get the benefit of taking the medication. Or if you're not getting enough weight loss, conversely, right? If you're not getting enough weight loss from your GLP-1, then you would want to put it maybe your lower right quadrant, maybe your upper right quadrant. You want the most nauseousness and the most lose weight aspect of it, put it in your upper left abdomen. That's the closest to your left vagus nerve, which is the most sensitive and the most nausea producing. It's the nausea, it's a low level of nausea that makes you not hungry, makes you go, nope, don't want to eat. Right. So if you're looking for the weight loss out of it, so it's also understanding how is the body wired? What is the the bioelectrical portion of the body? How is it wired and where do those wires go? What do they do? So understanding when and where just even to apply the GLP-1. Right.
Right.
So then that would lead us into how would you then add in a GLP-2? Well, is it more of a midgut problem or do you have IBS? Do you have this problem or that problem? Again, somebody who understands those things and, the people that we study with that train at, performance training, we go through those things about how the vagus nerve, where the vagus nerve is, what does it do? How does it respond? What are these nerves? What are those controlling nerves? So that biomechanical, that biochemical, and that bioelectrical. So having somebody who understands that as well is very important.
Yeah. And if you're a manual therapist and you want to learn more about it, come to class with us.
There you go. I would love to have more people come. Exactly. We would love it.
We'd love to help.
Yeah, exactly. And have people who focus in on certain things. I mean, that's really it's a call to arms of a sort of like, if you're going to do this stuff, let's do it intelligently. And then let's get enough people who really know what's going on with the body, with the human body to help accentuate the function of those peptides. So there you go. So that's the takeaway. Come take class and make sure you ask lots of questions. If you're going to use the stuff, use it wisely and use it complexly.
Thanks for joining us on another episode of OsteoSignal with Neil D. O'Neill. For more information, please visit pursuitpt.com or pursuitperformancetraining.com. Our music was written and performed by Sky Toes. Copyright 2026 by Neil D. O'Neill.